lecture in this DOS PEP or postgraduate education program series. If you are not able to join through the link, you can join through the YouTube link. That I think, Pranita, have you put it in DOS PEP group?
So I have already put the registration. I'll put it on the. I'll share the YouTube link now.
Okay, so you said that also. If there are any difficulty, then join through YouTube. The advantage of joining through this platform is you can directly interact. Okay. So I think, Pranita, you please introduce our speaker today and the topic, and then we can start.
Thank you, Dr. Praful. So, welcome everyone to the second lecture of our oculoplasty series for the DOS postgraduate education program. So, we have our two moderators for the oculoplasty session. That is Dr. Pallavi Singh. She's working in Ahmedabad as a private consultant. And we have Dr. Puneet Jain, who's a consultant of oculoplasty department in Sharpsight Eye Hospital. Our speaker for the day is Dr. Akriti Desai. She is an oculoplastic consultant at the Shantilal Sanghvi Eye Institute in Mumbai. She's an ex-faculty from LVPI Hyderabad. She's done a post-graduation from Delhi and worked as a senior registrar at the KEM Hospital. Also has had affiliations with the Shankar Nethralaya, which is a prestigious institute, and has done an observership at Julestein Eye Institute. Dr. Akriti today will be talking about how to work up a case of eyelid disorder. So on that note, I hand over the podium to Dr. Akriti. Welcome, Dr. Akriti. And
thank you so much, Dr. Pranita.
You can start sharing your slides now.
Okay, thank you. Okay, are the slides visible?
Yes, ma'am. You can make that full screen.
Okay, that's great. Okay. So, good evening, everyone. It's been a pleasure to be at the DOS IPEP. Let me start with the evaluation of eyelid and eyebrow. I've divided it in two sections, wherein we first discuss how to evaluate, and then we have a few case scenarios. So we would like it to be a little more interactive. Eyelid evaluation would encompass eyelid ptosis, entropions, eyelid retraction, ectropions, spasms, and tumors of the eyelid. Tumors could include benign as well as malignant. So let's go ahead and see how to evaluate each of these. But before we move on to that, a bit of the anatomy of the eyelid, wherein the eyelid position is determined by the protractors and retractors of the eyelid. The protractors means the muscles which close the eyelid, which include the orbicularis oculi, the corrugator supercilii. The orbicularis oculi is divided into two parts, the preseptal and the orbital. The preseptal is further divided into preseptal and pretarsal. The palpebral is further divided into preseptal and pretarsal. So these are the muscles which close the eyelid, and the muscles which retract the eyelid are the frontalis to a mild extent, but majorly the levator palpebra superioris, which we can see on the diagram on the right. And behind the levator is the Mueller's muscle. So these muscles determine the position of your eyelid. The word ptosis, which is one of the most common conditions seen in the conditions of the eyelid, is derived from a Greek word which means a fall. So I often get residents asking questions like, is this eyelid ptosis? How do we determine and how do we measure it? So this condition would not come in the definition of eyelid ptosis. We'll see why. The drooping of the upper eyelid with the eye in the primary gaze. So even if the eye is in the primary gaze, it has also got to be in its normal position and its size for you to assess the eyelid ptosis measurements. So there are causes in which there can be pseudotosis. These could be either ipsilateral causes or contralateral causes. So what does the gentleman on the right have? He has dermatochalasis and eyebrow ptosis, which is giving an appearance of droopy eyelid. His eyelid margin position is, in fact, in the normal range. The lady underneath has a hypotropia, which is once the other eye is covered and you ask her to fixate the right eye, her amount of ptosis improves. So she has an element of pseudotosis as well as true ptosis. So the causes of pseudotosis ipsilateral would be dermatochalasis, brow ptosis, hypertrophia, or deficient orbital volume, like you saw in the previous case, where there is either enophthalmos, phthisis bulbi, microphthalmos, or anophthalmos, that is absence of the globe. Contralateral ptosis could be because of lid retraction on the other side. Okay. So how do we grade ptosis? When it is mild, it is 2 millimeters of droop, moderate is 3 millimeters, and severe is 4 millimeters. When the difference in the two eyelids is 2 millimeters or more, it can be in cases of asymmetrical ptosis, like in all these cases, which have been demonstrated on your right-hand side. But in case of bilateral ptosis, these are the measurements which will guide you. In unilateral ptosis, it's quite easy. You can always compare it with the other eye. And it's always good to ask for old photographs, which will give an idea of what was the position before and why the patient has come with this complaint. History taking would be is quite vital, and there are things which as routine ophthalmic surgeons or ophthalmologists, we might miss to ask while assessing ptosis. So we always ask for onset, duration, and progress for all our patients, but it's also good to ask whether there is any variability in ptosis, whether there's any diurnal variation, whether it has been progressive, and also ask for old photographs. Like the gentleman on your right, he has severe ptosis when he presented, but his old photograph showed very good eyelid height and palpebral fissure. Associated symptoms of diplopia, any repeated allergies or edema is important to ask. And any past ocular history, because any of the intraocular procedures, especially where you take superior rectus or where the recti are handled, in fact, even inferior rectus recession surgeries will affect the position of the eyelid. Any previous contact lens use, especially the rigid contact lenses, but also seen with long-term use of soft contact lenses, they can rub on the attachment of the levator muscle to the tarsus and can thereby cause dehiscence and subsequently drooping of the eyelid. So that's why it becomes important. And any ocular diseases like dry eye help you to assess whether you want to correct it fully or you want to undercorrect it and decide on your further plan of management. Trauma is also important because in a case of traumatic ptosis, you would not like to intervene early, and usually we would wait for about 6 months to decide whether we want to go ahead, because many of the times it corrects by itself. Systemic history of dysphagia guides you to, would indicate or suggest possibility of oculopharyngeal dysphagia, oculopharyngeal dystrophy, or breathlessness could indicate ocular or an associated systemic myasthenia, any muscle weakness, or cardiac abnormalities. We'll come to why this is important. Okay. Now coming to examination, visual acuity, we definitely would assess for any to unearth any sensory deprivation, because it covers the pupillary axis or the visual axis. Strabismus in cases of strabismic amblyopia or any astigmatism. If there's a mass sitting over the eyelid pressing on the cornea, it is likely to cause astigmatism. Inspection would include what is your position of the head. A lot of patients, especially when they have bilateral ptosis, would have chin elevation if the ptosis is severe. If it is still moderate, sometimes they can get away with just frontalis overaction, that is by raising your eyebrows. It's important also to look for periocular scars. So before you go on to the test, it would be good to inspect any features which are like telltale signs of what could be the underlying problem. Then Hirschberg's test is something that would help you assess in cases of strabismus, because the eye that you're evaluating should be the fixating eye. Palpation is also important. Many times people feel that it's one of the most missed tests while assessing ptosis, and you don't want, there have been like quite a few misdiagnoses that I have also encountered when palpation is not done in cases of ptosis. We'll discuss a couple of those cases. Now, this gentleman on the right, as you can see, he has left eye ptosis, but he also has this different texture of this upper eyelid skin, which is typically called as cigarette paper skin. So this is seen in cases of blepharochalasis, wherein that history of repeated allergic edemas is important because the constant eye rubbing and constant stretching of the eyelid skin and resolution of edema causes this kind of texture to the upper eyelid skin. Okay. Then the rest of the examination is pretty much the same. Is size of pupil and reaction, and it becomes important in third nerve palsies. Extraocular movement limitation would become important in even to diagnose any Duane. So movement, you have to see the position of the eyelid in adduction and abduction. Is there any restriction, or there is any gaze-evoked diplopia? Slit lamp examination, heterochromia iridum is seen sometimes in congenital ptosis of Horner's syndrome, wherein there is inverse ptosis as well due to the existing Horner's syndrome. And look out for cataract, whether the patient has been previously operated or no. That I don't have to mention. Everyone looks out for cataract. Fundus examination would help you in pigmentary retinopathy, which is seen in CPEO, chronic progressive external ophthalmoplegia. Corneal sensations, if they are poor and you correct the ptosis, then the reflex blinking if it's affected, then the surface will get damaged. So in such cases, you might decide to be more conservative. Schirmer's test, how good is the bells, and the eyelid position in down gaze. In congenital ptosis, there is eyelid lag. In down gaze, the eyelid is little higher. Whereas in aponeurotic ptosis, wherein the levator is disinserted or affected, the ptosis is worse in down gaze. So the position of the eyelid in down gaze assessment becomes important. Look out for any lag ophthalmos or any Marcus gun by asking the patient to move the jaw sideways. Herring's test also, I'll show how it is done and why is it important. And fatigability, Kogan's lid twitch, and eyes tests are important from ocular myasthenia gravis point of view. There are about 5 measurements which are to be done in cases of ptosis. MRD3, which is margin reflex distance 1 in up gaze, is not always necessary to evaluate. MRD stands for margin reflex distance. Margin is the eyelid margin, eyelid lid margin, and reflex is the pupillary light reflex. So distance between the pupillary light reflex to the upper eyelid margin is margin reflex distance 1. Whereas distance between the pupillary light reflex to the lower eyelid margin is margin reflex distance 2. Whereas palpebral fissure height stands for margin reflex distance 1 plus margin reflex distance 2. Margin crease distance, we will cover all of this in the subsequent photographic documentation, so it becomes easier to remember. So what are important while assessing, taking these measurements is your as an examiner, your eyes should be aligned with that of the patient. So if the patient is a child, you need to come to his or her eye level to take these measurements, otherwise they'll be erroneous. So the eye also needs to be in primary gaze. So if there is any kind of strabismus or occlude the other eye, it is taken as the distance from the corneal light reflex to the upper eyelid margin and in the pupillary plane. The significance, it helps you grade ptosis, and if at all the ptosis is covering the eyelid position is lower, is covering the pupillary axis, it is measured as negative MRD. So when the eyelid is bisecting the pupil, your margin reflex distance would be 0. If it is above the pupil, it will be +1, 2, 3, 4. And if it is below, It'll be minus 1, 2, 3, 4. Now, why palpebral fissure height? Traditionally, it was measured and thought it could give you an idea of ptosis. Now, why it won't is that it's measured in the pupillary axis from the upper eyelid margin to the lower eyelid margin. Normally, it is 9 to 10 millimeters. And the drawback of measuring this is it can be misleading because there is eyelid retraction. Although this patient has ptosis, this patient's MRD, palpebral fissure height is 9 millimeters, but he also has ptosis. So it is not a good guide to tell you whether a patient is suffering from ptosis or not. Margin crease distance is the distance between the eyelid margin to the prominent eyelid crease. Some patients have multiple eyelid creases, so you have to choose an eyelid crease, which is the most prominent one. And from that skin fold to the eyelid margin is the margin crease distance. In men, it's a little lower, about 6 to 8 millimeters, whereas in women, it is higher, about 8 to 10 millimeters. Why is this important? Is that in aponeurotic ptosis, this eyelid crease recedes upwards and it becomes even higher. So the margin crease distance is likely to increase wherein there is levator detachment because of age or trauma or surgical intervention. So that will guide you what type of ptosis it is, hence it becomes important to measure it. The levator function is measured because this is often not done correctly. It is important to block the frontalis action with your other eye thumb and then ask the patient to look down. Your zero of your scale should lie in the visual axis at the eyelid margin, and then ask the patient to look in extreme upgaze. The excursion from this down to upgaze is measured with the help of a ruler, and that will tell you what is the amount of levator excursion. This is graded as poor when it is less than 4, fair when it's 4 to 7, good when it's 8 to 11, and excellent when it's more than 11. In children in whom we can't assess or who are less likely to cooperate, you can just evert the eyelid and see whether it reverts back to its position by itself. If it does not, then it tells you that levator function is likely to be quite poor. This is what I was talking about, why eyelid lag is important. This is a child of congenital ptosis, but she's also been operated with a sling surgery. And in down gaze, you can see post levator resection, there is eyelid lag in down gaze as compared to the other eye. Although in straight gaze, the position is normal. So this has also got to be explained to patient while counseling for surgery, that although in straight gaze, your positions of the eyelid might be normal, in down gaze post resection, it may not be symmetrical. There are some other causes of eyelid lag is apart from congenital ptosis. It is also seen in aberrant regeneration of the third cranial nerve, thyroid eye disease, myotonia, and anterior lamellar shortening. As in when the anterior lamella is the skin, when there is shortening of the skin, it does not relax enough for you to move the eyelid down. Now, this is how you would normally assess for lag of thalamus. Ask the patient to relax and close the eyelids. You would also be able to assess the bells. When you actually hold the eyelid and ask the patient to close to assess for bells, they are likely to squeeze and continue looking in the straight gaze. So it would be good to make the patient even maybe recline a bit and ask them to relax and close the eyelid so that you have a appropriate assessment. So bells is graded as good, fair, or poor, which will help you choose a good, proper line of surgery and decide on how much you want to correct and which is the procedure of choice. So bells is good when none of the no cornea is visible. It is considered fair when maybe less than 1/3 cornea visible, and half or more of cornea being visible is a sign of poor Bell's phenomena, wherein there is no rotation on attempted closure of the eyelid. In this, I will skip. So there is aberrant third nerve regeneration. In which cases do you see synkinetic ptosis? You could see it in pseudophone graphase, in inverse Duane's, and pseudo-Argyll-Robertson pupil. Marcus gun joinking, like I said, why ask the patient, if it's a child, you can even give him or her a small chocolate and assess whether there is blinking and flickering of the eyelid while the child is eating something. Or if it's an adult, you can ask them to move the jaw sideways from right to left and look for the position of the flickering of the upper eyelid. It is considered to be mild when it's 2 millimeter, moderate when it's 2 to 5, and severe when it's more than 5. For myasthenia gravis, Kogan-Littwich sign is very rarely seen, not very often. In this, we ask the patient to look down for about 30 seconds and then look back in the primary gaze. If there is a flick upward movement before coming back to its position, that will tell you that the Kogan-Littwich is positive. Fatigability test is done by asking the patient to constantly look up for about 2 minutes. You'll have to hold a finger or some pen to ask the patient to look up, and that if the patient is not able to sustain that position, it will guide you that fatigability is positive. For ice pack test, you cover the ice pack either with a gauze or tissue, because otherwise it can sometimes get painful, over the eyelid. And after 2 minutes, couple of minutes, look for the position of the eyelid. Like in this patient, ice pack test was done for the right eye. After 2 minutes, his ptosis has improved, which is very much indicative of positive ice pack test. Although it's not a definitive test, it's good to, it's an easy bedside test before you ask for any neurodiagnostic investigations or any blood investigation. Peak sign is something that it's not just the levator function that's affected in oculomyasthenia, even orbicularis is affected. So after a sustained period of eyelid closure, it will seem like the patient is peeking through the eye. And that will be one of your giveaways to diagnose oculomyasthenia. Herring's test is based on law of equal innovation. Now, how is the test performed is, one sec, I'll just explain it before I show you the pictures, is by lifting the other eye upper eyelid and see whether there is further, there is drooping of the fellow eye. When you lift up the ptotic eye, to look for the drooping of the fellow eye. The significance is that if after correcting the ptosis, there is likely to be droop of the other eye, and this has to be explained to the patient prior. There's also phenylephrine test, as this was a 53-year-old lady who came with left eyelid drooping. And after putting 5% phenylephrine in her ptotic eye, you can see how well it has improved the position of the upper eyelid. So this will guide you. It can help you decide that you would want to do a conjunctival mullarectomy, or like earlier Fasinella Savat was done. So that can help you choose the procedure if it, just after instilling a drop, it corrects the position of the upper eyelid and brings about better symmetry. Okay. So this is how manual elevation of the ptotic eyelid is done. The right eye is drooping, manual elevation of the ptotic eyelid is done, and after that you look if the other eye, upper eyelid, is drooping. It can also be done by, now this lady has right eye upper eyelid retraction and left eye droop. So you can even patch the eye for 15 to 30 seconds and see whether the retraction improves. That tells you that after correcting the ptosis, the retraction will improve by itself. This is another example of phenylephrine wherein the right eye upper lid droop has improved. Let us skip this. One must also be on the lookout for non-isolated congenital ptosis, such as in blepharophimosis syndrome or congenital LPS SR weakness or congenital Horner's. This would be the classification, but we need not do that. Also, look out for mechanical ptosis if there are any tumors. Like in this child, it's a capillary hemangioma which is sitting on the upper eyelid, which can cause eyelid droop or change the contour of the upper eyelid. So these would come under mechanical ptosis. Neurogenic ptosis is one, for example, like in third nerve palsy, you have complete ptosis. The eye is also down and out because of unopposed action of the lateral rectus. Okay. Then this is an important entity seen in young males, wherein there is bilateral ptosis. There is also ophthalmoplegia, that is extraocular motility limitation in all gazes. It involves the levator as well as orbicularis, and it spares the pupil. So pupil reaction in chronic progressive external ophthalmoplegia would be normal. Look out for systemic features. Do a proper dilated fundus examination to look for pigmentary retinopathy. And such patients don't do very well. You can't surgically correct, as they also have poor Bell's phenomena. At the most, if at all you want to try a tarsofrontal sling with silicone with undercorrection, can help them just cover the visual axis. Many of them use crutch glasses. Now, this is a very poor example of crutch glass being used by the patient, which was a metallic glass. Now we get much better crutch glasses available, wherein it has significantly damaged the skin of the upper eyelid of this man. So while diagnosing ptosis, you should mention all these 5 things, whether it is mild, moderate, severe, whether it is simple or associated with any other condition like BPS, like blepharophimosis or Horner's, or any of the CPO, for example, whether it's congenital or acquired. The last 2 features, how is the Bell's and the levator function, because it helps you guide what is the choice of procedure and how much correction are you aiming for. So make sure all this is mentioned. What determines whether the post-op corneal exposure will be there is how good is the strength of the orbicularis. So you can even manually lift up the eyelid and ask the patient to forcefully close to give you an assessment of how much is the orbicularis oculi function. Bell's phenomena should be good. There should be no lag of thalamus. Tear film should be stable and corneal sensation need to be good. So these determine whether the cornea is likely to get affected post-surgery or not. After ptosis, let's look at eyelid retraction. Which is most commonly seen in our scenario in thyroid eye disease. And a classical feature of this is retraction, which is more prominent laterally. The normal contour of the upper eyelid is such that the palpebral fissure height is maximum in the visual axis, is in the pupillary plane. Whereas in thyroid eye disease, there is lateral flare. This is because of multiple reasons, like lacrimal gland involvement, thicker horn of the LPS laterally, the inflammation causing more retraction laterally. So the contour has changed and the palpebral fissure height is more, vertical palpebral fissure height is more seen laterally than medially. Likewise, this is upper eyelid retraction. Normal position of the lower eyelid is at the inferior limbus, and if it is not at the inferior limbus and it's below the inferior limbus, which will tell you that there is retraction of the lower eyelid. Now, I have put this video just for a quick assessment because sometimes it's overwhelming, especially for residents who are more used to seeing the patient on slit lamp, to do an external examination in those 10-15 minutes of your available time for your practicals. So in examination of eyelid, we measure first the contour of the eyelid, which is highest at the pupillary axis. Eyes open. So this is where the contour is the highest, and we measure the MRD1, that is margin reflex distance, is from the center of the pupil or the pupillary light reflex to the upper eyelid margin. It's best to use an opaque scale for margin reflex distance 1. So if your marking is at 0, then about 4 or 5 would be your MRD1, depending on what is the position of the eyelid. In normal position, it covers about 1 to 2 millimeters of the limbus, and lower eyelid position normally is at the inferior limbus. Whenever there's a contour change or retraction, you would get a different MRD1 and MRD2. So, palpebral fissure height is not an ideal measure, whereas margin reflex distance 1 will actually give you assessment of ptosis better. Because in case that there is lower eyelid retraction, the palpebral fissure height may be good, although there is ptosis present. The other thing that you need to examine is close your eyes, whether there is any lag of thymos. How is the eyelid crease? How is the symmetry between the two eyes? Please open your eyes. And are there any lumps or bumps on the eyelid which are visible, or there are any skin changes? The next thing to examine in the periorbital area is the position of the eyebrow. The best position, like in women especially, the eyebrow is located at the orbital rim margin, and the highest position of the brow is from the line drawn from the ala of the nose through the pupil, where the line intersects the brow, is the highest position of an ideal brow. Now, how to measure levator action in an adult would be to block the frontalis. So for the left eye, you would use your left hand thumb to block the frontalis, because frontalis is a muscle which is extends from it up to the medial 2/3 of the forehead. So this is where your frontalis exists and lifts the brow. The lateral aspect, lateral third of the eyebrow is not supported by frontalis muscle. So by blocking the action of the frontalis for the left eye with your left hand, request the patient to kindly look down, ma'am. Look down, close your eyes, please look down, and please look up to the sky, up. So here you can see the frontalis action is about 20 millimeters, which is excellent frontalis action. Then we also check the tendons. So medial canthal tendon is checked by lateral distraction. Lateral canthal tendon is checked by medial distraction, or if there is rounding of the lateral canthal angle. So if you're able to distract the punctum more than 2 millimeters, there's mild laxity. When you're able to distract the punctum up to the limbus, it is moderate. And beyond the limbus, if you're able to distract the punctum, it is severe eyelid laxity. The next is the distraction test, where you pull the eyelid, and if you're able to distract more than 6 to 8 millimeters, there is some amount of eyelid laxity. And the snapback, these are the tests done for Entropion and Entropion, where you pull the lower eyelid and see how quickly it reverts to its normal position. It should normally go back to its normal position immediately, but if it takes a while, it takes a blink to revert back, then this would be normal. Suppose it takes a while to go back, it will be mild laxity. And if at all the snapback is poor, then the patient will need to blink for it to revert back. And if it is worse, then the patient will need to, in spite of everything, it will never go back to its normal position. So it's graded as snapback is good. Fair would be with a delay. Poor would be with a blink, and even severe, like even poorer snapback is, it never reverts back to its normal position. Okay, that took a while and there was some repetition, but coming to now Entropion and Ectropion, as you can see, this lady has right eye lower lid, severe Entropion, and there is rubbing of the eyelashes on the ocular surface. She also has quite amount of laxity, which is guided by the amount of fat prolapse that you can see in the lower eyelid. As discussed previously in that short clip, there is severe laxity of the medial canthal tendon. You are able to distract it beyond almost up to the pupil, not beyond the pupil, but almost up to the pupil on lateral distraction. And there is significant medial distraction of the punctum as well. The distraction test is also positive. More than 8 millimeters, you're able to distract the lower eyelid. And snapback, of course, we need a video. It's not very visible, but you would pull it back and see how quickly it reverts back to its normal position. Now, why palpation is important? Such a condition, I guess many of you would have seen, and this is not a condition which is often misdiagnosed. You would end up palpating because it's at the lateral orbital rim. And you look whether the lesion, the mass, which is seen at the lateral edge of the eyelid, whether it is adherent to the overlying skin or the underlying bone, and you are able to lift the skin of the mass or not, and whether the lesion is freely mobile in the upper eyelid, which will tell you the depth and the layer at which it is involved. So here, this patient, which is a very common condition, had a external angular dermoid. So it comes from the sutures of the frontal bone and the frontal process of the zygoma, due to which it's not very mobile and it seems like it's attached at the bone, but the overlying skin and the tissue over it is freely mobile and you are able to lift it off the lesion. Now we'll have a quick case discussion. This patient, as you can see, has a hypertropia of the right eye, along with, it seems like there is some amount of eyelid retraction. But in fact, on correction of this hypertrophy by our strabismologist, the eyelid looks ptotic. And there is also inferior eyelid retraction. This is secondary to inferior rectus recession. So this patient had to undergo ptosis correction and some amount of retractor release, but there is still some residual lower lid retraction present. Sorry. Yeah. Now this child, as you can see, left eye has a little bit of asymmetry in the contour. There is not much ptosis, but there is more of drooping laterally. Now, this child, if I would not have palpated it, I would have easily missed something like this. He had had a fall from a few feet, which had fractured his... One second, I'm just sorry about the disturbance. Give me a second. Sorry about the interruption. Yeah, so this child had this fracture of the frontal bone, which was pressing on the eyelid and causing the contour change. And hence palpation becomes important. Now, this patient came with a complaint of post-trauma many years ago and with severe watering. There was not much redness though. But as you can see, there is a lot of defect in the lower eyelid, just medial part of the eyelid margin, little bit is available, but rest of the eyelid margin is missing and there is a large scar on the lower eyelid. So this would be a diagnosis of cicatricial Entropion, which can be corrected with skin graft and you just flap off from the upper eyelid or any other method, but this is what I chose to correct. So what you look for, this is grade 4 Entropion. Entropion is graded if there is just eversion of the upper eyelid, any eyelid margin, it is grade 1. If you are able to see the palpebral conjunctiva, it is grade 2. If you are able to see the inferior fornix, it's grade 3. And if you're not able to see even you are able to see beyond the inferior fornix, even the bulbar surface of the inferior fornix, then it would be grade 4. And also look out for an anterior lamellar scar, which is visible. Now, this patient had, as you can see, there's a lot of corneal surface defect, there's epithelial defect, and he has an entropion of the upper eyelid. why I brought this slide, it's vital. Oftentimes, the entropion of the upper eyelid is due to a scar present on the tarsal surface. So it's important to evert the eyelid and look for any scarring of the tarsal surface of the conjunctiva, and measure the tarsus also. Sometimes patients have undergone some multiple surgeries, and some of the surgeries, the tarsus has been removed or incised. So the height of the tarsus, which is about 8 to 9 millimeters, it's important to measure it to see whether there's any defect or deficiency in the height of the tarsus. Now, this lady has undergone 2-3 procedures before, and apart from the eyelid position that there is complete ptosis, you are able to see that there is fullness of the temporalis fossa, which is seen just above your zygomatic rim. There is fullness over there. Now, that fullness is because if you palpate this lesion, you will get a bag of worm field, which is classically seen in plexiform neurofibroma in neurofibromatosis 1. So that kind of palpation will guide you that this is likely to be plexiform neurofibroma, and it is extending into the temporalis fossa. The next case is a lady with, you can see there is asymmetry and there is a lesion in the medial eyelid, which is changing the contour of the eyelid a bit. It is important to make measurements of any eyelid masses in up and down gaze to see whether they become prominent or less prominent in either of the gazes. So here in up gaze, you are able to see it's getting a little more prominent because it's coming through the septum as the septum moves behind. And whereas in eyelid closure or in down gaze, it becomes less prominent. So she had an upper eyelid superomedial venolymphatic malformation, which can be either by palpation, it will cause a soft lesion. If at all there is a defect in the upper eyelid, wherein in cases of encaphalocele or meningocele, that lesion will also have pulsations. So when you put your hand over, you may not feel a thrill, but you will be able to see the pulsating lesion, which will require you to investigate further or ask for an imaging to know the diagnosis ahead. Coming to more simple conditions, like this lady has xanthelasmas of the upper eyelid, which are yellowish deposits. So like for any, as you would have learned in any of your surgical postings before, that I'm saying general surgery, like any mass should be measured where its size, its consistency, and size, I mean dimensions and all, like horizontal, vertical, and the height of the lesion, the color of the lesion, whether there is any rubor, dollar, any signs of inflammation, and whether there are any prominent vessels over it. If the lesion is towards the eyelid margin, you also comment upon whether there is any loss of lashes or distortion of eyelid margin architecture, that is the meibomian glands. So these are the features which you should take into consideration for assessment of any eyelid lesion. Smaller xanthelasmas can be just removed surgically, and they do pretty well. Now, the other commonly seen lesion are eyelid nevi. It could be heavily pigmented or almost amelanotic nevi, and you need to evert a bit to see that the eyelid margin is not involved when the lesion is more like primarily anterior. Sorry, this is somehow gone. Okay. Okay, the next case is a case of sebaceous gland carcinoma. We are able to see that without eversion, we just know there is a lump in the medial eyelid, right upper eyelid, with some distortion of the eyelid margin architecture. But on eversion, sometimes you may not be completely able to evert, but to whatever extent it's possible, or you can ask for assistance. You can see the yellowish multiloculated deposits with prominent vasculature around it. There is no dilated tortuous vein, but the vessels around it are little more congested. And there is distortion of eyelid margin architecture, which will tell you that this is a sebaceous gland CA. If you're in doubt, one can always do an incision biopsy before going ahead with a more definitive excision and reconstruction. So to summarize, a detailed history and methodical examination are vital to come to a diagnosis and decide upon an appropriate line of management in any of the eyelid conditions. Thank you. I am open to take any questions or any comment from other panelists and moderator.
Thank you, Dr. Akriti. That was a wonderful lecture, and with so many cases, videos, and photographs, I'm sure the students must have benefited a lot. The moderators, would you like to make any comments before I proceed to the questions from the students?
No, I think just echoing your emotions, Dr. Pranita, because this is probably one of the most extensive lectures I've heard on eyelid examination. Sorry for the bad lighting in my video, but I think the students should really save it to go back to it again and again. So if you would like to proceed with the questions, or we can start, whatever you feel is fine.
Yeah, I think before the entire lecture of oculoplasty is proceeded, this is one of the most important lecture, that is examination is something which is very basic and needs to be dealt with all the students. So, Dr. Praful, any comments you want to make, sir?
It was a wonderful talk. Congratulations, Dr. Akriti. I think I missed a lot of it because we are simultaneously going through a constitution committee meeting. But I think it was perfectly done, and students must have benefited for this. And thank you so much. This is what even while planning this program, this was there in our mind. Monday lecture, it will be didactic. Thursday lecture, it will be like teaching them the practical aspects. You perfectly did that job. Thank you so much.
So let's, thank you so much. We can take the questions from students if they have, because it would be more interactive and it will help them in further classes.
Dr. Anita Sankla, she has raised a question. I think she has some doubts regarding Marcus Ganjo winking grading system. If ma'am, you could look into the chat box. She raises a question on the grading for mild, moderate, and severe for the cutoff criteria. So could you throw some light on that?
Yes. So while suppose if you're able to see my face, when you ask the patient to move the jaw from side to side or open the jaw and move it this way, the flickering of the eyelid, upper eyelid margin, when it is 2 millimeters, it is mild. When it is 2 to 5, it is moderate. And if it is more than 5, suppose the upper eyelid is going beyond the limbus, then it is severe. So the reason why grading becomes important, patients who have mild amount of lift on movement of jaw, like it's going up, down, very minimally up to 2 millimeters, then they would be probably not having Marcus gun as their primary complaint. Their primary complaint is ptosis. So if you do a libator resection, they are likely to be happy. But if they have severe Marcus gun, which is like 5 or more, then by correcting ptosis, they will still complain to you that they are not happy because that movement has persisted. So you might have to excise and do a sling. So this needs to be discussed with the patient prior. Hence, the grading becomes important. So it's 2 to 5 and more than 5.
I think she has some confusion. She's read somewhere as less than 4, 4 to 6, and more than 7. I think different books, different cutoff criteria. That is something which is inevitable to ophthalmology and any medical.
True, there are multiple grading systems for everything, but the crux is you need to discuss this with the patient. What is their primary concern and what can be solved and what cannot be solved, so that they have a realistic expectation.
So there's another question by Dr. Pallavi, you want to add on?
No, I was just saying that from what I also remember, and it's been a long time since I read my textbooks, but that what Dr. Akriti is saying is right. That I think that I don't know where the source is, but it's 2 millimeters, because that mild, 4 millimeters, if you just think of it yourself, that's a lot of movement. So it's 2, and then like you said, 2 to 5, and then more than 5. I think you should stick with that.
So the current guidelines, am I audible?
Yes, sir, you're audible.
Yeah. So the current guidelines for American Academy, I think I remember this correctly, is mild, moderate, severe, 2 or less, less than 2, 2 to 5, and 6 or more. And you can quote this as American Academy guidelines. So I think in a Viva, you do need to tell from where you have read this. Sometimes we have read from textbook that shall not be named. So that's always a dilemma in exams. So you can quote this. So it is less than 2 to 5 and more than 6 for mild, moderate, severe markers in jaw.
Yeah. So, okay, ma'am. So we'll move on to the next question. Dr. Ashwin Govil has raised a question. Can we differentiate between surgical cause or paralytic ptosis on examination?
That paralytic ptosis is when there is paralysis of which muscle that you are looking at, unless it's third nerve palsy, is which you can definitely differentiate on clinical examination. And surgical cause of ptosis, on history, you will be able to make out, and also if you can see if the patient has undergone cataract surgery or RD surgery, due to which there could have been traction on the superior rectus. So,
if I could add to this, so
yeah,
whenever you have a paralytic cause of ptosis, it's going to be because of third nerve palsy, right? Because that's what supplies the levator. In those cases, your levator function is going to be very poor. So that's the main thing. And in cases of surgical, now depends on what kind of surgery are you talking about. Are you talking about neurosurgery that affected the third nerve? Then it becomes paralytic ptosis. If you're talking about direct trauma to the eyelid, then in the initial phases, you might find that the levator function is low. But as time goes by, which is why whenever a patient comes to us with traumatic ptosis, we always try to wait for at least 4 to 5 months before we do any surgical intervention, because they tend to regain their strength. So if you are seeing a case of traumatic ptosis, say after 6 months, the levator function will be much better as compared to a paralytic ptosis. Dr. Akruti, do you think that sums it up?
You rightly pointed out that if it's a neurosurgery, then it is still traumatic ptosis. I mean, it's still paralytic ptosis if the third nerve is involved.
So one point what you can do if the examiner does ask you this question, which is it's actually very non-specific question, is you can check the extraocular muscle movement. So like Pallavi rightly said, that in third nerve palsy you have to justify whether it is third nerve palsy or somebody has done let's say a very shoddy job with LPS and it has completely fallen, which is extremely unlikely, but yes, plausible. So then you can just check the extraocular movement. Having an isolated LPS palsy, I don't think I have seen any case. So there will be some superior rectus involvement, definitely, if at all it is a branch kind of a palsy. So if the patient looks up and the superior rectus muscle is normal, then I think you can, and all the other extraocular muscle movements are normal, then you can safely say that it's not paralytic. Then rest of the causes obviously would ramify depending on whether it is neural or we're talking about LPS surgery, heterogenic damage to LPS, and so on. I think that
that's a very vital point, because the superior division of the third nerve does supply the levator and LPS together. So most likely both are involved.
Yeah. So I think we can move on to the next question. That's the last question. So what are the causes of temporal fullness? Dr. Sonali Pradhan has raised this question. What are the causes for temporal fullness?
So what lies in the temporal area of the upper eyelid, just underneath your lateral orbital rim, superolaterally, is the lacrimal gland. So one of the causes is any lesion or tumor or inflammation of the lacrimal gland, which will cause temporal fullness. And external angular dermoid, which comes from the frontozygomatic suture. Pallavi or Dr. Puneet can give
now
their
again, the question can be taken in two ways. One is temporal fullness and one is temporal fossa fullness.
Okay.
Now the causes of both, I think the person is trying to ask temporal fossa fullness, but that's okay. What you answered is absolutely fine. So you can twist the examiner also sometimes by being very picky with what he or she says. So you say temporal fullness or temporal, you give answer for both. Now temporal fossa fullness becomes a different, a different differential diagnosis category, which probably would be beyond the scope of this discussion. Neurofibromatosis and a lot of things.
I think
there could be a double dermoid possibly, which causes which is involved in temporal fossa.
हमें पास होने से मतलब है और हमें देखो whatever has to be done, it has to be done in the interest of the society and truthful. ये तो मैं हमेशा एक फैक्टर लेके चलता हूँ.
I think we have some
ठीक है. As I said, आज एक कदम हम.
Thank you, sir.
Yeah, for the entertainment. So there's another question by Dr. Suhas Sanklapura, who is how to measure MRD1, which comes as negative value in severe ptosis as light reflex is not seen.
Right, that's a good question because it's a practical problem that you can come across. So when there is severe ptosis, you put your scale at the zero mark of your scale at the eyelid margin of the upper eyelid. You will not be able to see the light reflex at that time, but your zero should be at the eyelid margin, and with your other hand you lift till you see the light reflex, and that difference would be your eyelid would be your negative MRD, whether it's -1, -2, -3 or -4. That's how I do it, and that's how I've been taught. If there's any other way that you do it.
I think, I mean, you just, you have to be, so one of the ways is what Dr. Akruti said. The other thing what you can do is that you can measure the distance between the upper eyelid margin and the lower eyelid margin. And then you can, see and when you lift up the eyelid, you can see the different, the light reflects to the lower lid margin and subtract the two. So if you just think of it logically, I think the most important thing is just, it's an arithmetic problem. I don't think it's as much of a practical problem like Dr. Akruti said. You can lift it up and, see it.
It is not at all difficult because your light reflex to the inferior corneal limbus is about 5 or 5.5 millimeters.
Exactly.
That you are very certain of. So depending on how much cornea is seen, you are able to know whether it's -2, -3, -4 or whatever is the level. It should not, it's not so difficult.
Exactly. So normally your MRD2, which is the distance between the light reflex and the lower eyelid margin, is 5 to 5.5 millimeters. So if the amount of cornea you can see is say 3, then you know that -2 is what is under the eyelid, right? So -2. If you can see only 2 millimeters, then it becomes -3. If you can see only 1 millimeter, it becomes -4. So I think, that's, I think especially for exams, the most important thing is you should know how to measure something rather than in your practical getting 1 millimeter, 2 millimeters, right? Because we still can't do this. Even, I mean,
and there will be difference of opinion between any two clinics in 0.51. So much of difference will always exist. So
rather than arguing with the examiner, then saying that 1 millimeter mera sahi hai, just say yes, and you to be clear with your concepts. I think that's important. So
when you're examining a case of ptosis, we usually get confused in which gaze what to measure. So just get your simple concepts right, that MRD is measured in primary gaze, LPS is measured from extreme down gaze to extreme up gaze, marginal crease distance is in down gaze. So all these things, they seem easy, but when you are there and answering these questions, you might get confused. So stick to, like Pallavi said, stick to these measurements and be very precise about these measurements. Do not forget to neutralize the frontalis, which is very common mistake. You immediately start measuring, ye to mujhe aata hai, and then you forget to frontalis. Sometimes you get to just read up the downward movement is inverse Bell's phenomena. I was asked this in my PG exam. So just read it up. It happens after ptosis surgery. It can happen physiologically. There are causes also. So just stick to the basics when it comes to ptosis. Entropion, ectropion, I feel are relatively easier when it comes to examination.
I think we have had a wonderful session and a wonderful discussion. Thank you, Dr. Akruti, Dr. Pallavi, and Dr. Puneet for that wonderful discussion in the session. So I would just like to thank all the viewers for being live with us. We had more than 100 students who were connected live during this session as of now. And just to brief you up for the upcoming classes, the next class is scheduled for 12th of August, which is benign eyelid lesions and tumors, which will be taken up by Dr. Puneet Jain. And the subsequent class will be on the 15th of August, which will be on lid margin abnormalities that will be dealing with entropion and ectropion primarily. So thank you. Good night, everyone. And thank you for being with us.
Thank you. Thanks so much, Dr. Pallavi, Dr. Puneet, and Dr. Pranita. It was lovely to be here. Bye-bye. Have a good night.
Good night.